want to welcome everybody. This talk has been sponsored by Catalyst. Although it seems obscure, I think it underscores some of the clinical aspects that we sometimes forget about when we're dealing with our patients. All the associated syndromes that can occur. So this, I'll be focusing specifically on LEMS, Lambert-Eaton Myasthenic syndrome and small cell. But I think these are my disclosures. I think it's important to really put this in the context of paraneoplastic, which really for this conference we don't have a specific talk. Paraneoplastic syndromes are quite common, particularly in lung cancer. We see dermatologic syndromes. I'm dealing with a patient right now as dermatomyositis, a combination of rash and proximal muscle weakness that is really required more than just systemic therapy. We see a whole host of hormone-mediated syndromes. SIADH is quite common in small cell, low sodiums that are often refractory. You see other associated syndromes, particularly in small cell, including ectopic ACTH, that can lead to Cushing's-like syndrome. Hypercalcemia, squamous cell, frequently, not just lung, but head and neck cancer, but a variety of other malignancies, including multiple myeloma, mediated by PTH-like hormone. And then hypoglycemia, insulin growth factor, again seen in lung mesothelioma as well as sarcomas. Probably a good 5 to 10% of our patients, if you really delve well enough, you'll find some sort of paraneoplasia. Cachexia in many instances is probably also paraneoplastic. And then we have hematologic and neurologic syndromes. Hematologic eosinophilia, which can be seen in a variety of heme malignancies, including lymphoma and CLL, but also in some solid tumors, including lung, and granulocytosis, leukocytosis. I've seen large cell patients with white counts of 90,000, 100,000. Of course, everybody panics. They assume the patient also has leukemia or CML, but it's just a reaction due to hematologic growth factors. And then finally, a host of neurologic syndromes that are really primarily in the realm of small cell or thymic tumors. The one I'll focus on is LEMS, but there are a number of others, including cerebellar degeneration and limbic encephalopathy. You can see the mediators, which can be assayed, looking for antibodies to PK fiber in cerebellar degen and anti-U in limbic encephalopathy and autonomic neuropathy. And then myasthenia gravis and thymoma, which is often confused with LEMS, looking at acetylcholinesterase receptor antibodies. So all of these are assayable, diagnosable, but often unrecognized, even though they can be quite common. Paraneoplasia, by and large, has an unpredictable course. It may postdate the diagnosis by months, if not years, and treatment may or may not help. Systemic treatment for the underlying cancer can sometimes put it in remission or can have no effect whatsoever, and frequently these individuals require additional therapies, immune modulatory therapies, including IVIG, plasmapheresis, etc. The neurologic paraneoplasia syndromes are generally immune-mediated disorders. Symptoms, as I said, can occur way before the cancer diagnosis. If you detect it and diagnose it, that should lead to an immediate cancer workup, certainly enhanced cancer screening and early interventions. And intriguingly, early initiation of treatment may potentially improve patient quality of life and outcomes, as I'll show you. Small cell constitutes 15% of all lung cancer. At one time it was 25%. Certainly when I started out 1,000 years ago, it was much more common. Probably half the papers at ASCO were small cell. Now it's about 10 to 15%. I think it's representative. This was a diagnosis when I was in medical school where we were told basically, tell the patient to get their affairs in order yesterday. So it's this really small cell that compelled me to go into oncology because I was led to believe it was totally untreatable. I think our whole biology of disease course in medical school on cancer was a day and a half. The small cell section was about 20 minutes, and it was just bleak, bleak, bleak. And then second rotation as an intern, attending admitted a small cell patient. and said, well, the patient was short of breath, hypoxic, trailing an oxygen tank, big pleural effusion. We'll tap the effusion, give them chemo, and send them home. And then 3 weeks later, they'll come back for the next cycle. And I thought, 3 weeks later? Won't be here. 3 weeks later, that woman came sauntering in, oxygen tank gone, effusion gone, no longer short of breath. I was sold. That was basically my ticket into oncology. So as bleak as outcomes have been, and still are to a large extent, they certainly improved. And it was happening even back in the 80s when I was doing my fellowship, although not recognized by the larger public. But nevertheless, much more aggressive tumor, high mitotic rate compared to other lung cancers, high nuclear to cytoplasmic ratio. These cells are small in comparison to non-small cell, but they're not small by any means. If you compare them to neighboring red cells, they're quite large. High cellularity and necrosis. If you look at it under the microscope, there's a lot of nuclear molding and a lot of melding together of the cells. Very high incidence of paraneoplasia, as I've told you. The neuroendocrine markers are usually, not always, but usually positive, including synaptophysin, chromogranin, CD56. High number of mitoses per high power field. And though we look at TTF, thyroid transcription factor, as generally diagnostic for non-small cells, particularly adeno, it's positive in small cell in about 80%. So really histology remains the mainstay of diagnosis. And we know that neuroendocrine markers and other endocrine factors may potentially influence the development of paraneoplasia. So here again are the neurologic paraneoplastic syndromes in small cell. Incidence is relatively low. For Lambert-Eaton myasthenia syndrome and LEMS, about 1 to 3%. And the big issue is we're probably under-recognizing this. We get patients who, for some reason, even though their disease burden is not advancing, they become incredibly weak. They start manifesting neurologic symptoms. It's important to keep these syndromes in your radar. You can see the distribution of other paraneoplastic syndromes, some of which I've mentioned, but also sensory neuropathy, encephalomyelitis, retinopathies, stiff person syndrome, opsoclonus and myoclonus. I've had 2 patients with that, and the various antibodies and markers that can be used to diagnose each of these syndromes. So LEMS specifically is a rare immune-mediated disorder. It affects the neuromuscular junction. It's characterized by muscle weakness and autonomic dysfunction. 50 to 60% of those with LEMS are associated with underlying cancer, most commonly small cell. Median onset for LEMS a bit younger than small cell, about 60. And the vast majority of those with LEMS and small cell are male, but that's true of small cell in general. Pathophysiologically, the IgG autoantibodies in LEMS will bind to VGCC voltage-gated calcium channels on the presynaptic membrane and reduce calcium influx. That reduced intracellular calcium will limit the excitosis of acetylcholine vesicles, and this decreased ACH release will in turn result in reduced muscle fiber contraction and muscle weakness. So the therapies that can result in enhanced ACH release have, including amifampridine and other agents, been shown to improve symptoms in patients with LEMS. But first, you got to recognize the syndrome. In retrospective analysis of claims-based data for those with small cell and LEMS, amongst the 76 patients who had the data, the majority were diagnosed generally around the time the small cell carcinoma diagnosis was made, usually within 90 days. Only in 12% was the LEMS diagnosis more than a year after small cell. So there's definitely still a temporal relationship, although you can see it coming on, the neurologic symptoms coming on way before the clinical symptoms, small cell, and sometimes vice versa. This is a delta score, the Dutch-English LEMS tumor-associated prediction. So you can see the scoring categories here on the left. Dysarthria, dysphagia, chewing trouble, neck weakness, you get at least a point for that. Erectile dysfunction in men, another point. Weight loss, which of course is nonspecific but seen commonly in small cell, another point. Tobacco use, again associated with small cell. Older age, a point, in declining performance status. And basically, If you've got LEMS, you obviously do a workup for lung cancer, specifically small cell. Perhaps relax the follow-up if you don't find it. If you have a lower delta score but a higher delta score, you keep going at it to really try to look for the underlying cancer. The symptoms are often nonspecific and vague at onset. Some proximal muscle weakness, again, autonomic dysfunction. I can't remember the last time I've actually tested reflexes in clinic. I no longer carry a reflex hammer. I figure the neurologist will do that for me if I have high suspicions. But hyporeflex or areflexia after rest period is common. And then post-exercise facilitation of tendon reflexes. The facilitation of tendon reflexes will happen in this disease and typically not seen in myasthenia. This is the most common symptoms that present generally within 3 months of LEMS onset. So again, proximal leg weakness is the most common, virtually everyone. Distal leg's a bit less common. So again, you can confuse this potentially with dermatomyositis or other proximal limb weakness syndromes. Proximal arms, about 72%. Eye complaints, so ptosis and diplopia. Remember, you can see that in myasthenia as well. That tends to come on later. The reverse is true with thymic paraneoplasia. Bulbar complaints, including dysarthria, dysphagia, chewing problems, neck weakness, and about a third to half the patients in cerebellar signs. And autonomic symptoms, so in men, sexual impotence, dry eyes, dry mouth, orthostasis in about a quarter, hyperdiaphoresis in about 11%. So again, individually, many of these symptoms are nonspecific, but in aggregate, they will potentially point toward the identification of LEMS in small cell. So the weakness generally starts caudally and will spread cranially, sort of the opposite of myasthenia, where ptosis may be the first presentation. Generally spreads over time from shoulders and hips to hands and feet. Mild ocular and bulbar symptoms can appear later in the course of the disease, usually in those who are severely affected with weakness. Again, unlike myasthenia. Severe enough, it can lead to respiratory failure. In that sense, like myasthenia, like Guillain-Barré, the speed of progression is generally much faster in those who have LEMS associated with cancer rather than those where LEMS seems to be occurring independently. And progression obviously is going to contribute to a heightened disease burden. Study of patients with LEMS, the disease duration from prior to study ranged from 2 to 39 years. 75% had partial or major restriction in their ADLs. Basic stuff like rising from a chair, climbing stairs, all had issues with mobility, ranging from some difficulty and virtually all to severe problems in about 10%. So obviously, the earlier you recognize this, the faster you can potentially improve patient mobility and reduce their restrictions of ADL. Ironically, despite this, prognosis is actually better in this group. They seem to have improved longer overall survival compared to small cell patients who do not have LEMS. So here are some series, mostly from Europe, looking at neurologic symptoms with small cell versus those without. If we look at the group with extensive stage disease, median survival, again, it's very small numbers, 27 versus over 20,000 individuals. The survival is much worse for the general population. And then the same is true for the limited stage patients. 49 patients versus 13,000, but generally better prognosis. And these are all of those survival curves superimposed. Of course, the limited stage patient doing better than the extensive stage patient. This is actually a video showing the gait that exists with LEMS. So it begins with lower limb muscle weakness, generalized fatigue. As I've mentioned earlier, can be confused with other syndromes, as well as the symptoms of small cell or the effects of the drugs that we're giving. So particularly in this IO era, and we know that checkpoint inhibitors can induce neurologic problems. That's certainly within the differential. Patients, in addition to this gait disorder, can exhibit difficulty in standing up from a seated position, climbing stairs, and walking. But one of the important things to do, and we can do this very easily when we're evaluating patients, just watch as they walk, get up onto the exam table. The differential is wide, frequently misdiagnosed. The majority of patients who are diagnosed with LEMS had at least one misdiagnosis prior, and over a third were misdiagnosed with myasthenia gravis, as you see in the pie chart here. 35.7%. Other muscular abnormalities and nearly 30%, so that was the majority. In the mean time between the patient's first visit to a physician for LEMS symptoms and a confirmed diagnosis, particularly in the absence of cancer, was over 4 years. How do we diagnose it? Well, the confirmatory test is a blood test. Anti-VGCC antibody, it basically voltage-gated calcium channel antibody confirms the diagnosis. You can potentially confirm it further with electrodiagnostic testing, high-frequency repetitive nerve stimulation, or post-exercise facilitation tests, and that'll differentiate this from myasthenia. The NCCN guidelines do include this entity, LEMS, along with the other paraneoplastic syndromes that I've already mentioned, so it is in the mix. Of course, it's a single line there. But remember, up to 7% of our patients will develop paraneoplasia, and some of these are somewhat obscure. So once more, 90% of patients with LEMS will have elevated levels of VGCC antibodies, and a negative antibody test, however, does not rule out the diagnosis, and EMG and electrodiagnostic testing should still be done. Clinical improvement can be seen if you treat the underlying cancer, but it's not a guarantee. Symptomatic treatment is recommended along with the anti-cancer therapy. Immune modulatory therapy can provide short-term benefit in the management of LEMS, certainly recommended for flares or symptomatic treatment. So therapies that increase the availability of acetylcholine, such as amifampridine, or inhibit the degradation of ACH, such as pyridostigmine, are also treatment options. Probably should be initiated sooner than later. I think once you've got the diagnosis, I would do these immediately. So again, you assess small cell patients for weakness, difficulty standing, any sort of new onset generalized weakness. Drop in ADL should be a prompt to do a paraneoplastic screening. And I wouldn't restrict that to small cell. I would do it with non-small cell too, particularly in this era of malignant transformation that we see all the time with those with oncogenic drivers. If LEMS suspected, order the antibody test. Obviously, engage the neurologist. This is beyond our usual expertise as medical oncologists. And as far as I'm concerned, the management of our patients takes a village and not single individuals. LEMS management is shown here in addition to amifampridine, IVIG, plasma exchange, steroids, azathioprine, rituximab, which we use not infrequently with IO-mediated toxicities. All of these have a potential role, particularly in patients who are not really benefiting from amifampridine. What about immune checkpoint inhibitors? There's been this general credo that if somebody has paraneoplastia, particularly if there's a neurologic condition like myasthenia, that you shouldn't give these drugs. Well, the problem is we don't know. The systematic review exploring the role of checkpoint inhibitors, which now we use ubiquitously in small cell, both in extensive stage and after chemoradiation and limited stage. Overall evidence for a causal link or any link exacerbating underlying disease or the paraneoplasia is low. And it's really due to lack of prospective trials. So somebody has to be brave and actually initiate IO therapy in this group before we can get any data whatsoever. Take-home messages: prompt identification of LEMS and appropriate screening for small cell may help improve outcome in both conditions. Patients with small cell and neurologic paraneoplasia, including LEMS, may have improved survival. The treatment of LEMS symptoms in patients with cancer is important, obviously, to improve and preserve quality of life. You can see a clinical improvement with the anti-neoplastic therapy, but more often than not, you're going to need additional supportive therapies like amifampridine. Course can be quite variable with frequent fluctuations, remissions, as well as permanent disability, and this is true of paraneoplasia in general, not just LEMS. And for patients with moderate to severe weakness, again, early institution of therapies is important. We'll end with a case study. 67-year-old presents to the ED with chest pain, worsening cough, and shortness of breath. Cardiac workup is negative, which obviously would be the first question that would come up in such a patient. Review of systems, loss of appetite, 5-pound weight loss, pain in the right hip, muscle cramps, prior medical history, not unusual for a 67-year-old 50-pack-year smoker, hypertension, peripheral artery disease. Usual medications, lisinopril, atorvastatin, aspirin. Vital signs shown here. The physical exam is not terribly remarkable. Diminished tendon reflexes, have to hand it to the internist that's actually testing that. Essentially clear pulmonary exam. And here's the scan. I think if we put this on a board and asked which diagnosis is going to be associated with this, and we gave a choice of small cell, adenocarcinoma, metastatic disease, most of us would pick small cell right up front. You see a big, bulky subcarinal node, peripheral disease, which may or may not be present in these individuals. And here's the PET showing both the primary as well as hilar and paratracheal nodal disease and a rather large metastasis to the right ileum. So standard extensive stage small cell patient, confirmed on bronchiebus, brain MRI fortunately is negative. Extensive stage in our institution, this person would get carbo-topicide atezo. You could easily make an argument for carbo-topicide durva. Extensive stage, I tend not to use cisplatin. I don't feel it's a quality of life drug in this setting, whereas in limited stage, I'll almost always use it unless there's a contraindication. So you see an improvement over time. Tishian and Leals actually provided these slides, so I think this is baseline and this is after treatment with a decrease in cough and chest pain. Unfortunately, as is generally the case in extensive stage small cell, about 5 months later the patient experiences progression with worsening mediastinal adenopathy and new bone mets, and at that point is noted to have lower limb muscle weakness and difficulty rising from a seated position. And within 2 months of the complaints of weakness, the patient's in a wheelchair, so a steady downhill course. Here's how the diagnosis was made. Again, more thorough neurologic assessment, no cognitive impairment, generalized bilateral lower extremity weakness with hyperreflexia. Sensory evaluations normal. VGCC testing was ordered, and it confirms elevated levels of the antibodies with LEMS, pretty much not just suspected, but the diagnosis, I would argue, is secured. So the patient started on amifampridine, 30 milligrams a day. You can titrate up by 5 milligrams a day every 4 days or so to a final dose of 60 milligrams. And patient reports an improvement in lower extremity weakness, only needing a walker occasionally, no longer using a wheelchair. In my clinic, I use the exam table test. If the patient can get up on the exam table on their own steam, they're up to any systemic treatment I can offer. So, you know, in a wheelchair, but if they can get up on the exam table on their own, as far as I'm concerned, they are treatment compatible and treatment worthy. And I think it's important, again, folks with bad paraneoplasia, if their functional status, their performance status is compromised, they're not going to be up to the systemic treatments that we have. So with that, I will end.